Welcome to the Natasha Helfer Podcast. To help keep this podcast going, please consider donating at natashahelfer.com and share this episode. To watch the video of this podcast, you can subscribe to Natasha's channel on YouTube and follow her professional page at Natasha Helfer, LCMFT, CST-S. This podcast addresses many topics around mental health and sexuality. It may not be suitable for minors. Some topics may elicit a trigger or emotional response, so please care for yourself accordingly. The views, thoughts, and opinions expressed by our guests are their own and do not necessarily reflect the views or feelings of Natasha Helfer or the Natasha Helfer Podcast. We provide a platform for open and diverse discussions, and it is important to recognize that different perspectives may be shared. We encourage our listeners to engage in critical thinking and form their own opinions. The intro and outro music for these episodes is by Otter Creek. Thank you for listening.
Hello, everybody. Welcome to the Natasha Helfer Podcast, where we try to attack sexual shame from any means possible. Any means possible. Education, stories, research, all the things. That's the main thing that we do here. And I'm super happy to have both Larry and Ricky Siegel back on the show. They have been with me for a long time in my journey of sexual health and sexual training. They've been wonderful mentors. I would say that I really credit the Siegels for very early in my sex therapy career, figuring out once and for all why the sex addiction model was so problematic. I knew it was problematic, but they gave me the language and the kind of the structure and the scaffolding per se to really kind of understand it, and along with several other professionals who we've had on the show. So, I mean, Ricky and Larry were really more on the show when it was called Mormon Sex Info, since I was still a member of the church and I was doing a lot of kind of education to the Latter-day Saint and Mormon audiences. Ever since my excommunication, I went more towards podcasting under my own name. But it's kind of the same show, same show. And I think a lot of the same people tend to listen to my views, which are, either progressive or mixed faith or nuanced Latter-day Saints and Mormon folks. Plus, of course, a lot of people who are leaving the Mormon traditions and wanting to figure out sexuality. Anytime you're going through faith transitions, there's so many different things to kind of think through worldview wise, and sexuality is definitely one of them. So without further ado, I'd love to give you both a chance to kind of give a small introduction of who you both are, where you come from, what kind of floats your boat, and what you're really into, and then we'll get into a discussion.
Sure.
I'll let my big brother go first.
Oh, okay. Well, first of all, I am so delighted to be here with you. I really am. It's always a treat to be able to get to talk to you and, the people that you're listening to. You do such amazing work. And, we have such just, there aren't the right words, right? The respect, the appreciation, the admiration for, what you've been doing and how you have persevered in doing this work. It's just, it really is truly, again, words I don't often use, but there's kind of inspirational in so many ways. So I really appreciate the chance to spend this time with you again.
Thank you.
I am primarily a sexuality educator. I did spend a number of years as a therapist as well. I like to say that my epiphany several years ago was that as much as I enjoy helping people and as much as people need help, the reality is, as today's conversation will show, is that the people who are helping people need more help than the people they're helping, especially in areas like sexuality and another area that I do specialize in pharmacology. When we look at the medical aspect and substance use and medication use and how all of those kind of figure into that big picture. So I've been doing this for, about 35 years. Right? And I'm still just as dedicated today to moving that needle than I was when I was a pie-eyed, still somewhat idealistic young sex educator. I think a lot of what keeps us in this work is the fight. and not wanting to give up and sort of let things fall into those patterns that they seem to want to fall into, or I should say, a lot of social forces want them to fall into. Again, I think part of the conversation that we're going to be having shortly.
Yeah. Thank you so much for that. And yeah, it is an ongoing fight, and I'm glad that you're in it. Like, I feel like sometimes I ebb and flow. I'm like, oh, I already did 10 podcasts about that topic. I can't do it anymore. And then it's like, and then I get all riled up again, and I'm like, oh, we need to come back. Anyway, so yeah, Ricky.
Well, hi. I just echo everything Larry just said. I'm just delighted to be back with you, and been a bigger thrill to watch your journey and your growth in this field, and the travails you have gone through personally and professionally have just been amazing. So I'm equally as thrilled to be here with you, to be back here again with you. I am the co-founding director of Modern Sex Therapy Institutes, a postgraduate training institute which primarily trains medical and mental health professionals to do sex therapy and sexuality counseling, and with the help of brilliant supervisors like Larry, sexuality educators as well. As you both know, this topic has been kind of an ever-present thorn in the side of folks who are trying to teach clinicians how to have a truly sex-positive, affirming approach to help them deal with the anxieties that sexuality often causes in individuals, in our own skin, and in relationships, in interpersonal sexual interactions, and families and parenting, of course, as sexuality educators know, really across the board in every aspect. So I did start as a sexuality educator, and was with Planned Parenthood for many years, and realized that what little counseling was being done in the clinics was really focused on clinical issues like STDs and birth control and pregnancy options, and was not being done by counselors. And educators at Planned Parenthoods all over the country tend to go out and about in the community. And so that missing piece prompted me to go back to school for a counseling degree and jump over to the more clinical side. And of course, as Larry said, having the opportunity to train therapists who are actually doing the work with patients is just as, if not more, rewarding than working with patients.
Perfect. Thank you so much. That's great. I think I titled this podcast like Addiction, Compulsions, Impulsions, oh my. Because these words just get thrown around so, I think, irresponsibly, right? And have real implications for how people perceive themselves, how people perceive their partners, how clinicians perceive their clients, right? And I think there's just consistent confusion about these terms. And how could there not be, especially when we as professionals don't have really a combined take on these things, that we amongst ourselves cannot get on the same page. And
it honestly has been one of the real frustrating things, because we're supposed to, right? There's supposed to be an implied message in our ethics and how we work professionally, that we agree to all speak the same language, especially diagnostically. And, as we all know, the word addiction is not a clinical term at all. It does not appear, except in a footnote or two, in the DSM, the psychotherapist's field guide to diagnosing mental illness. And it's really been frustrating, among the long list of frustrating things with this whole topic has been seeing our peers, our fellow licensed clinicians, using this unhelpful, unclinical language just because it's popular among the lay public. And, there is no such disorder or diagnosis as sex addiction. So instead of using this language that we already have, there's this strong pull, I suspect, fueled mostly by this popular obsession that we have, especially with porn and with masturbation and fantasy, and what is the normal way to have sex and the normal frequency. So I think even just starting there with talking to our peers and professional colleagues, that it's all the more important that we speak the same language, regardless of what our patients come in with.
Right. And could I just add on to that, because I think that's a really good foundational point. And what I want to add on to that is it's kind of mind-boggling that it's not only about the idea of, we have a clinical language, and there's a way that we should be approaching our clients and patients in terms of how we help them. But there's also no other area in all of psychotherapy or psychoeducation where the therapists are taking their lead from the clients themselves. There's no other area in this field where we go by self-diagnosis by the client or patient, right? If somebody came in and said, you know what, I'm schizophrenic, nobody would say, okay, here's meds, here's the treatment, we're going to put you in. Right? We're going to look at that. We're going to explore that. We're going to see why are you saying that? What is that based on? But we don't do that with sex addiction, or I should say the people who are doing that work don't do that with their clients or patients. It is completely self-diagnosed.
Or partner diagnosed.
Or partner diagnosed, right? Which to me is kind of the same thing.
When the partner brings someone in,
that's right, by the ear.
They're an addict, fix them.
Right. So it would be different if part of this process does involve this being actually diagnosed by a clinician. But I really don't know any cases that ever were or that continue now to be. It's all basically client or patient diagnosed that the therapist just goes along with. And I think that is part of that inherent pathology that this whole concept and this whole label also holds.
I want to go back to something you said earlier, which is addiction is not a clinical term at all. And I want, because this is the first time I heard this was also from the two of you, that that's also true for substance use. Right. So the term addiction doesn't show up in the DSM, even for substances. We call it substance dependence. Mm-hmm. So can you talk a little bit about what we're, because I think that's what most people think about. It's like, oh, well, this is like being on cocaine, or this is like being on alcohol, right? That your porn is on, your brain is on drugs if it's on porn. And there's organizations that say that, as and they actually call themselves that. Porn is the new drug is kind of an organization. And so can you explain just a little bit of the substance use issues and how that affects the brain, and how there really isn't a correlate?
Well, yeah, I do think it's been a specious sort of leap of faith, if I dare, because of that notion of chemical dependency and, addiction having so many different definitions. See, one of the issues is that there's a pharmacological way of thinking of addiction, generally in terms of tolerance and withdrawal. If someone needs more of a substance to get the same effect they used to, and then there's a withdrawal syndrome in the abstinence of that substance, that's pretty clearly identifiable as addiction.
Right. And that's neurochemical and neurophysiological. That can be measured.
There is chemical dependence. And in staying in that medical pharmacological definition, it would stand to reason that if one has arrived at that place where their body is dependent on a substance and there is a withdrawal syndrome, a detox, if you will, then once someone completes that process and their body readjusts, they're no longer addicted anymore. Now try using that logic in another world, another culture, where addiction is defined as a permanent, lifelong, incurable disease, where all one can hope to do is keep it in permanent remission, right? And so like in typical Alcoholics Anonymous terminology, people get very upset if someone were to refer to themselves as a recovered alcoholic, right? Oh, no, you're recovering. You're always recovering, but you will always be an alcoholic. So then to apply this willy-nilly pseudoscientific approach to sex or the other so-called behavioral addictions, we've heard folks actually trying to use this pharmacological definition of tolerance and withdrawal and say, I used to masturbate 6 times a day and now I'm up to 14. That's clearly a sign of tolerance because the old masturbation's not doing it for me anymore. I need more and more intense fodder to fuel the fantasies, right? And if I don't masturbate for whatever reason, if I'm at a wedding or a family affair or have to go away on business, then I get cranky and irritable and I can't sleep and I'm anxious.
Anxiety.
That's withdrawal.
Right.
No, it's not. It's anxiety from not being able to engage in your go-to self-soothing, which generally sex serves an effective function in. So addressing that, I don't mean to ramble right out of the gate, but let me offer another example. No one in all of our years of doing this, we've never heard anyone, clinician, professional, or layperson, ever once think out loud, we need a new 12-step fellowship. We need an HWA program for Hand Washers Anonymous, because clearly we see people who are addicted to hand washing. Nobody thinks that way because we clearly understand that compulsive hand washing is an ineffectual coping mechanism for something like germ phobia, which we clearly see is an anxiety disorder, almost an OCD, that if we treat that, presumably the behavior will dissipate. And we can't seem to apply that same thinking to another behavior, whether it's masturbating or serial cheating or whatever other behaviors get lumped under this heading of sex addiction. We call the symptom the disease and effectively cut off the diagnostic process. Say, well, there's your answer. Just stop doing it and work a program of recovery. And how does that address what's going on?
Well, but in a way, it has that purpose, right? Because I think, and Natasha, you said something, just even part of your introductory comments, that is also at the root of all of this, that nobody is going into some kind of 12-step program or seeking some kind of recovery for hitting their head against the wall, right? Or poking themselves in the palm with a pencil, right? It seems to be the only behaviors that we pathologize in this way are things that make us feel good. Whether it is the use of food or love, because I mean, that's another thing. I mean, I'll go off for days on this whole love addiction, separate from sex addiction, and all that nonsense. But I think it really does speak to this underlying centuries, millennially old, just sex negative attitude of the shame and blame that we always associate with sex and pleasure. And, specifically to the rise of this sex addiction concept, I think in the first book chapter we wrote, it's still one of my favorite things because it was in one of those books called Taking Sides, where, they present two perspectives on an issue, and we presented our chapter on this side of the sex addiction debate, if you will, and the other chapter was written by Patrick Carnes, who's kind of the father of all of this kind of stuff, and we can trace this back to probably a single AA meeting in like 1983 in Boston, when a person stood up at this meeting and said, now that I'm not drinking anymore, I'm not using my drugs anymore, I find that I'm kind of using sex in the same way that I was using my drugs, as a way of not feeling, as a way of self-medicating, right? And I think what had happened is that that was like the biggest spark, to set off this kind of wildfire in an ideology, and kind of refer to it as a metaphor that has just completely run amok. Right? This comparison was really an analogy.
Yeah, I think it started even earlier. It started back in the 50s with research on alcoholism, and most of us remember a researcher named Jelinek with the famous curve, and the idea that alcoholism and chemical dependency later on were fit this disease model. And that was really, really important for overcoming the previous societal view that it was a moral failing.
Right.
This idea that, you need to get right with God and pull yourself up by your bootstraps and get back to church and stop drinking, that you need that strength. And this medical research provided more sympathy and more understanding, and this recognition that alcoholism untreated fits a disease model. Predictable symptoms, worsening of those symptoms, predictable outcomes. And as Larry said, the metaphor run amok, we've just sort of dropped that model part and have been screaming from the rooftops, it's a disease. The researchers said it is. It's just like diabetes or cancer. And come on, it's not.
Right. Right.
No, a diabetic doesn't, yes, there's some control over symptoms and eating right and managing blood sugar, but it's still ultimately a failing of a body part to produce a necessary hormone. There is no equivalence with alcoholism, except when folks try and describe it as an allergy to alcohol.
Right.
Right. But it's a disease model. It's not like this, hey, don't look to me for any responsibility, and you can't be angry at me because I have a disease. I'm not a cad. I have a disease. I need your sympathy, right? It's not my fault.
Mm-hmm. Mm-hmm. Yeah, and again, this yes but approach that we have with pleasurable, feel-good things. Right? You get the grudging acknowledgement. Well, yes, it does feel good, but you could do it too much.
Yeah.
Right? And we always put it on this sort of competing continuum, right? Yeah, anything that makes us feel good, there are these people that want to project it out into the area of, but it will cross a line, right? And we can, again, look at this historically. Everything that brings us pleasure has been looked at as a potential evil or a potential danger, right? And it does. I think, you asked earlier what's kind of changed in the rhetoric of the sex addiction industry. And I think there's one change that I can identify, and it's not a complete change by any means, but part of this idea of the pathological sex addiction or the dependency or this is not right. It's kind of based on this presumption that first and foremost, the real setting for sex is a heterosexual relationship. Right? That's one thing they've moved a little bit on. You'll see more people in that industry that will acknowledge same-sex relationships. But that's about the only thing, right? Because it's still based on this idea that if number one, you're supposed to be in a relationship, and number two, that relationship's got to be monogamous. Right? And anything outside of that script is inherently problematic.
Yeah.
So, with the in some cases grudging, in some cases maybe sincere acknowledgement that not all relationships are heterosexual. I think that's the only movement there on that side of things. The rest of it is still the presumption that there is a proscribed way and amount and context and orientation to a partner that sex is always supposed to be a part of. And this is just a deviation from all of that.
And it's really not helped by trying to use this 12-step model and this 12-step culture, because, whether it's Alcoholics Anonymous or 20-some years later, Narcotics Anonymous showed up in the 50s. And then by the 80s, there were 30, 40 different 12-step fellowships, but they all shared the same tenets of AA, which was, step one of the 12 steps, powerless over blank, and our lives became unmanageable. But fast forward to now, there are no less than 5 different 12-step fellowships specifically for sex addiction. And the real problem is they all define relapse and recovery differently. Right? So whether it's Sexaholics Anonymous, Sex Addicts Anonymous, Sexual Compulsives Anonymous, Sexual Recovery Anonymous, or now I guess the most popular, Sex and Love Addicts Anonymous. One of them says the addict sets their own bottom line behavior. Another one says if you fantasize, you've relapsed. Another one says masturbation of any kind is addiction, kink is addiction. In the beginning, as Larry said, being non-heterosexual was addiction. And the more progressive, I suppose, is you decide what your bottom line behavior is and where the line is. So, how's that helpful? That sounds like alcoholics saying, well, I can have 2 drinks a week because that's not too much for me. It can't be arbitrary, and there's got to be some consistent language.
Mm-hmm.
So again, with the clinical approaches, we have a lot of language. We have a lot of things that can explain symptomology, whether it's anxiety disorders, which my bias is almost always part of the picture, or personality issues, or more severe mental illness, impulse control disorders, compulsive behaviors. So even, as we all know, and I'm sure you've podcasted with him before, our dear friend and colleague, Doug Braun-Harvey, and his writing partner, Michael Vigorito, have written the book Out of Control Sexual Behavior, Rethinking Sex Addiction. And what we emphasize is, even with this preferred term by most sexologists these days, if we're talking about out of control, we need to always visualize an asterisk there and emphasize that the idea is feeling out of control, not being literally out of control. We've both have had students come to us in a panic. I think I'm a sex addict, or I'm a porn addict, or I'm addicted to masturbation. And we find out that they're engaging in this behavior once a month. And so imagine what else could it be other than a huge burden of guilt and shame that they're doing something so wrong that it leads to this disease, even if they're doing it once a month. I remember telling a student, dude, I could shoot heroin in my neck once a month and I'll never catch a habit, right? Addiction implies, even in the traditional foggy view of it, it implies some repetition, some behavior that's repeated enough that it leads to an addiction.
Well, that's a huge issue right there, because when you have people coming from conservative or high control religions, it's a zero-sum game, right? So when you say, well, you're repeating this behavior once a month, for a lot of these folks, that's how they see it, as repetitive behavior, because there's zero tolerance or zero allowance for human sexuality to just show up as natural, right? That's a natural drive. Like me getting hungry 2 or 3 times a day is fairly natural, right? It doesn't really matter what background I come from. My body is going to have that natural drive to want to eat or drink water. And so there's no
allowance from that either.
That's right.
Right. So if I'm a water relapser or something, I don't know. But it's like, but there's no ability to really acknowledge that or to allow for that. And even in these 12 steps programs, when you're talking about masturbation and pornography use being seen as relapses, again, we're identifying monogamy very, very in a kind of this weird way, right? Because even my relationship with myself can't be counted as part of our monogamy. When I think of non-monogamy, I think about having sex with other people outside of our partnership if I'm partnered. But it seems like in a lot of these cultures, it's like even having sex with myself is considered non-monogamous.
Yes.
Yeah.
Right.
And there's a lot of overlap in our profession, and particularly these subgroups of folks who claim to specialize in these areas. A lot of overlaps with affairs and the idea of fidelity and betrayal. That way too many people, I don't want to get off our subject here, but just in general, way too many people are of the mistaken belief that if they're in a relationship with someone, they somehow claim ownership over that person's thoughts and feelings and fantasies and dreams. So that if my partner is even thinking about an attractive movie star on the screen, I have to get upset and entitled to be angry that you're cheating on me. Mm-hmm. Your sexual energy is going anywhere in the world other than to me. And I'm sorry, but that just does not align with human behavior, with the fantasy machine we all have between our ears.
Or logical behavior. Right? I mean, take that a step further as well. We've been talking about this for years also, that, ever since Viagra and those kinds of medications have been available, you may have one partner comes back, maybe the partner was complaining that there's an issue here because he can't get an erection. And now it comes home with this medication, say, guess what? Now I can get an erection. And the partner's like, if you can't get that just from me, I don't want anything to do with it. Right?
I'm insulted.
You're supposed to be, responding, and all of your desires and all of your urges and all of your responses are supposed to be about me. Right? And if you're not getting sexually turned on just by me, now I'm insulted and I feel betrayed. And I think this underlies a lot of those same kind of dynamics that we have not been able to, I think, clean up from how we look at relationships.
Yeah. Well, and I think most of us come from what I call the ownership model of relationships, right? It's very romantic, I guess, in a song to say, I belong to you and you belong to me, until you start really understanding what those words mean. And then it is just a bunch of control and ownership instead of negotiation and sharing, right? And I think that's something that, hopefully in marriage counseling, we're doing a better job of talking about. But so moving forward though, so we talked a lot about the word addiction. It's problematic. It's even problematic in the substance abuse world, and what does it mean? And do people take this, perspective of like once an addict, always an addict, even with substances, versus just saying, okay, you are no longer physically addicted to this, but, psychologically, do you have to see yourself as pathological the whole time? There's been a lot of critique about the 12-step program. I know the 12-step program has helped a lot of people with sobriety, and I know it's really kind of not helped a lot of people with sobriety. So it's even in the substance abuse world, where I think it has most of its research, it's up in the air, right? As far as effectivity, whether or not we have research really sustaining, whether or not these programs really work, what do these words mean? So now the next thing that comes on the timeline is this ICD classification for compulsive sexual behavior. Now, granted, we already have compulsive behavior in the DSM. Mm-hmm. Already have compulsive behavior in the ICD, I believe. But no, we got to make it special, right? Sex always has to be special, right? We have to be really special and focused, laser focused on anything that has to have to do with sex. And so I feel like even though the intentions behind this disorder were not necessarily CSAT focused, the sex therapy, the CSATs, which is the Certified Sex Addiction Specialists, really saw this as a win. And now everything, instead of calling everything sexual addiction, now we're calling everything compulsive sexual behavior. So I would love to have a conversation about what the heck does this what does this even mean? What does it actually look like? And how is it? Yeah.
The predecessor was hypersexuality, which honestly for 30, 35 years, folks have been trying to get into the DSM. And the answer was always like since DSM 3 or 4, 4 or 5 versions since then. And the problem was always defining how much is too much, and a complete lack of any research basis on trying to define this. In the addiction language, what's the point of unmanageability, right? So as we said earlier, I think before we went live, this was a source of huge excitement that the sex addiction industry could now say, see, we've got our diagnosis. Give them credit. They've been patient and persistent, waiting for 40 years. But they've got this ICD-9, the International, more medical than mental health diagnostic index of sexual compulsivity. But if you just do a cursory Google search and look at the background leading up to this, like on PubMed, you will find that it leads with 4 or 5 paragraphs clearly delineating what it's not, right? So there's a lot of language on ruling out what is the cause of the distress. If it's a mania, if it's a bipolar kind of disorder, if it's a personality thing, if there's, as I said before, with out of control sexual behavior, the only times we've ever seen literal out of control behavior is with traumatic brain injuries and some Parkinson's patients where the dopamine levels get so high that it causes what appears to be out of control behaviors. Other than that, it goes back to that feeling of out of control and the guilt and shame that goes with it. And we know that the research from a lot of our colleagues has really zeroed in on particular demographics, which, as we all know from personal and professional experience, is about mostly white Christian guilt. Right? You don't see a lot of sex addiction in communities of color. And there really does seem to be this common thread about doing something we're not supposed to and feeling guilty about it.
Yeah. And that really is at the core, because hypersexuality, out of control, sexual behavior, sex addiction, one thing that nobody, I don't care how into that concept they are, I don't care how professional they are, they cannot tell you what the definition of too much sex is. And one of the things that has been shown very, very clearly in research around the world in the last 10 years is that the people who do use these labels, out of control, hypersexual, I can't control it, it's constant, they actually in general have less sex than people who don't connect to those labels. So it really is, I think, a very, very clear matter, right? Again, going back to the shame and blame package that so much of this comes in, that it's not about the sex that people are having that's at the root of this. It's about how they feel about it. And then again, all of that, particularly white Christian guilt, that shame around sex, that pathologizing sex and sexuality is what this is all about, right? So this really becomes not about sex or sexual behavior. This is this values behavior conflict. I'm doing something, but in my head, I shouldn't be doing this. I'm not supposed to like this. So that's really the root of the problem, right?
Yeah, I have to add
behavior.
I have to add that there's a piece of, if it's not too harsh a criticism, I really don't care, but a piece of iatrogenic harm, wherein the clinician is contributing to the problem, primarily by making the crisis that the couple or individual shows up with the new permanent. Because again, that traditional view of addiction, however unclinical it may be, is that it's a forever thing. You once an addict, always an addict. All you have to do is live in this hypervigilant state of keeping it in remission. And my bias as a sex therapist is I don't want anybody I work with to see their sexuality as diseased or broken or something out of their control that they have to live in fear of. Sexuality is what we are as human beings. And
Yeah, exactly.
we have volitional choice in the decisions that we make.
Right. So again, coming maybe you're saying from a perspective of a sex therapist or just a therapist, how about the perspective of a human being with a logical thinking brain that we see that it's kind of unethical if you really think, if you take a step back and think about it, somebody's coming to a therapist, they're supposed to be coming here to get help to feel better. And I don't think it's even in the periphery of this discussion, but this label of hypersexual or sex addiction or out of control, it is iatrogenic. It does cause an increase in distress and depression and anxiety. Right? And some people may have not even had a high level of that coming in, but now they're given this label and now they're really, in high gear with their distress. So I think from that standpoint, there's a really unethical aspect of therapists and professionals. Forget medical professionals. I mean, they're all about creating pathology.
Yeah.
Right? And let's face it, a lot of us that are in these fields, there's a need to justify our own existence sometimes by kind of creating a lot of these pathologies. And Ricky and I are a little bit different. And I think Natasha, you as well, kind of share a little bit on this as well, even if you don't verbalize it this way. But we're trying to put ourselves out of business, right? We're trying to put all of us out of business.
In every case.
Create a greater need for what we do. We want to create, people don't need what we do anymore. Right. But that's kind of the opposite of what I think people in this field and who, will professionally use these labels. They're creating this dependency. They're creating this distress so that people feel more helpless.
Would you both say, I don't know if you'd say it this strongly, but would you both disagree with this disorder having been put in the ICD-11? Do you think that there's usefulness for this disorder? I mean, just to give the public. So it's like compulsive sexual behavior disorders characterized by a persistent pattern of failure to control intents. Who gets to define intents? Right. And all sexual behavior intents, repetitive sexual impulses or urges resulting in repetitive sexual behavior. And I think most sexual behavior is repetitive at some level, right? So again, who gets to decide what level of repetition? Anyway, symptoms may include repetitive sexual activities becoming a central focus of the person's life to the point of neglecting health and personal care or other interests, activities, and responsibilities. Again, with partners, I see this as very subjective, right? That you're neglecting me or you're neglecting our sex life. And so who gets to decide all of that? Numerous unsuccessful efforts to significantly reduce the repetitive sexual behavior. So it's this, you've got to have this idea that you've tried to stop and you haven't been able to stop. And this is why it feels out of control for people. Mm-hmm. And continued repetitive sexual behavior despite adverse consequences or deriving little or no satisfaction from it. Well, adverse consequences, again, I mean, we live in a fairly sex negative world. So, I mean, it was pretty adverse just to be gay not that long ago, right? And so, I mean, who gets to decide why we're having adverse consequences? Then it says the pattern of failure to control intense sexual impulses or urges and resulting repetitive sexual behaviors manifested over an extended period of time, 6 months or more, and causes marked distress or significant impairment in personal, family, social, educational, occupational, or other important areas of function. And then there's this last sentence that drives me even more nuts, which is distress that is entirely related to moral judgments and disapproval about sexual impulses, urges, or behaviors is not sufficient to meet this requirement. But when you go back to the previous sentence, which just says personal, family, social, educational. I mean, how do you not have tons of moral judgments that are fully supporting this disorder? So, I mean, do you feel like this is a disorder that shouldn't even be in the ICD?
Well, I go back to my first example. Why don't we have compulsive hand washing disorder? Why don't we have compulsive Facebook disorder or compulsive YouTube or TikTok disorder? I know there's been an effort to
get much more of an issue,
right? There's been an effort to get gaming in this category because, yes, we see kids who are spending 10, 12, 20 hours a day ignoring school, ignoring their family, zoning out. And again, as therapists, I want to encourage that diagnostic curiosity to explore personality issues, anxiety issues. What is this medicating behavior attempting to medicate? We have impulse control disorders. We have compulsive disorders. We have a whole language in therapy to zero in on what may be contributing to this distressing behavior. And I don't know why sex needs to be any different.
No, and again, going back to sort of a comparison to, substance use, and I think this is something that all therapists need to do a better job of understanding and being trained in. Every diagnosis we can look at on a continuum. Right? I don't care what the diagnosis is. Every diagnosis exists on a continuum. Now, part of this continuum is, guess what? It falls within the range of normal human behavioral and emotional patterns. But we can go to a part of that continuum where it may become an issue. Now it may be presenting a little bit of, I don't even want to say a problem yet, but it's something that they may have to recognize and start thinking, be a little bit more conscious of, because then there's that other part of the continuum where it can be problematic. Right? So we don't just say, oh, we hear a word and we go right to the other end of this is a diagnostic problem, right? Even in substance abuse, I think there's this huge distinction that needs to be made. And I can revolutionize the entire substance abuse industry with this one little piece right here. That if we just take people that come in that say they are out of control, they say they are addicts, right? Their use has become a problem. And if we just separate this population of substance abusers or chemical addicts into two groups, one group of people whose maybe recreational use did start to get out of hand. Because with substances, there is a physical tolerance that can develop. For those people, you sort of break that cycle, you break that momentum, they're done. Right? And they're done. They're finished. Addiction is no longer an issue for them. But they are qualitatively different from the other population that needs to be looked at and treated differently. And these are the people that they're using not because they like it or enjoy it. It always starts out that way, but that's not their main reason. They're medicating. They're trying not to feel anxiety or depression or something, some kind of trauma. So the self-medicating people, for them, you break that dependency. Now their work first begins, because now you've got to look at why were they using? What were they trying to self-medicate and cover up? Because if you just stop the behavior and you don't deal with those underlying motivations, they're just going to keep trying to self-medicate. Right? And I think when it comes to something like even sexual behavior, we need to be able to look at it in these similar kinds of spectra. Right? Is somebody got a real problem? Is this a truly compulsive behavior? Is the person really out of control, whether it's perceived or, again, due to some kind of organic issue? How do we break them down, and how do we to look at non-shaming? Seeing, helping people see that, all right, yeah, this is something you've been doing. You feel that this is out of control. but you do have the control. Let's look at what it is you're running away from. Let's look at where the issues you're trying to use this to feel good and medicate really are. What's going on in the relationship? How do you feel about yourself? We've got to break it down. This idea of we latch on to a word or a term and then we go with it. Even in other diagnoses, that sort of self-distress, for me, I don't really consider much at all, right? A lot of people look at that as a primary factor. Personally, I don't, because we know, especially in this area, how many people will feel a high level of distress where they really don't have a reason to. And there are people that have really good reason they should feel distressed about their behavior, and they don't.
I'm sorry. I know time is getting away from us, but I think we'd be remiss if we didn't at least acknowledge the relationship aspects to this, because I can just piggyback on that point exactly, that a lot of that distress isn't felt until the bust.
They get busted.
And now the partner's distress is the source of the patient's distress. And a lot of what gets swept up under this is, I believe, especially our obsession with porn in this country, is that we're still too squirrely to talk about fantasy and masturbation. And so what happens too often, I've said this often, the sex addiction model, in quotes, is the most perfectly designed thing I've ever seen to destroy the lover's dynamic between a couple. Right, because the partner of the addict gets put in this parental or probation officer, detective kind of role, right? So invariably there's the bust. Oh my God, I busted him looking at porn. Why would you be doing that if you have an available partner? You must have a problem. So of course, not wanting to get in trouble with mommy, there's always the lies. Oh, I promise I'll never do it again. Which, of course, she is not signing on to that promise. That's a promise made to get out of the doghouse. And so invariably there's going to be another bust. And now it's, oh my God, you said you would, you promised you wouldn't do it again, and you did. So you clearly must have some out of control problem. And secondly, you promised me. And so there's a betrayal. And now we've taken a really unhealthy relationship dynamic and used it as gasoline on this fire of made up kindling.
Yeah, and the therapist is right in there with them. While you were talking, thank you for bringing that up, by the way. I think that's really important, Ricky. While you were talking, Larry, about this, let's look at whether or not something is, having a medical type of use, that we're kind of numbing our symptoms, everything. In some ways, I feel like this is what CSATs will say, though. See, this is what we're doing. We're just looking at trauma. We're looking at why you're using sexuality in these very unhealthy coping mechanisms. And so I'd like to, because I think, again, the public is hearing us, and I think they're hearing a lot of confusing information, right? So what makes it different from what you were just describing, Larry, from somebody who's going to take a sex addiction approach and is saying, well, we're just going to look at your trauma and how these things are coping negatively in your life?
Well, again, and I'm glad, thank you, because I know sometimes, just in a small amount of time, try to get sometimes too much information in. But I think one of the biggest differences is I wouldn't look at that, if there's trauma, right? If there is that other stuff back there. And by the way, I don't agree with them when they say that that's what they focus on. They don't. That's the excuse that they use to carry the label forward. All right. So, and again, I don't think we can deny that there are people that do have struggles with their sexual behavior and the way they think about it. Right. I mean, that is a truth. But I think that label and that diagnosis are completely off base, because I think the simplest way I can say it is they are confusing a symptom with a diagnosis. They are making a diagnosis out of the symptom, and where that sexual difficulty they may be having may be a reflection and an expression of some things that they are struggling with. It is not a primary disorder. It is not the thing that they need to be focused on. That's just how they are acting it out in their life and in their relationship. So the focus should never be on the sex per se, but rather, where is their shame? Why are they feeling this sense of shame? What do they lack in terms of sex education? Because a lot of this is driven by people just don't know what they're supposed to be doing. They just don't understand what healthy sex or sexuality is. And I think the biggest issue is this so-called sex addiction or hypersexual or out of control sexual stuff. It's not about sex. I'm going to repeat what I said before. It's about this conflict between their values and their behavior. And what they really need help in is this values clarification and reconciliation to be able to bring these things together and own their stuff. Because this is what's called sex addiction, right? And again, where the CSAT people, I think, are pretty much off base.
Yeah.
Right? There could be underlying stuff, but this is not about the sex. Right? By pathologizing the sex, they're not helping anybody. Right? But the fact is, we can, and just like I don't agree with food addiction, but can people use food to try to medicate these emotional issues? Yes, they can.
Yeah.
Right. So, but I wouldn't say they're food addicts because I don't believe in food addiction. So,
Well, how do you treat that? It's like telling a cocaine addict, look, you can only have 3 little lines a day
Right.
now. Because, one little bump for breakfast, one little bump for lunch. No, you need to abstain from cocaine. But you can't abstain from food, and you can't abstain from being a human sexual being. You can't
Exactly.
say, I'm not gonna,
because
I don't believe in erections.
desires anymore.
Yeah, we had a conversation with so many college students that it practically got scripted. These guys that would come up in a panic. I think I'm a sex addict, or I'm masturbating every day. And I would love to ask them, if you were having sex every day, would you be standing here and having this conversation with me? And invariably, they would always say, oh, I wish I was having sex every day. To which I could say, you are. Right? And I'll let you in on a little secret. Your penis doesn't know there's no one else in the room with you. Right? A healthy, loving sexual relationship with yourself is a sex life. Right? But no, we have these scripts, masturbations for lonely losers who can't get laid. So if you have a partner, you don't need that anymore. So any discovery of that is automatically problematic. And it's just plain wrong.
Right.
We have somebody on who's asking some questions. Dan Hardy is on here asking questions, and he typically likes to push the envelope, doesn't agree with me on much. But he's basically saying, so is that not an addict control problem if you can't keep from looking at porn when you've promised your spouse you would stop, right? So that's one comment. And then he's like, you really don't believe there's any such thing as porn addiction or food addiction? And yes, Dan, we don't believe that. But anyway, that's the typical pushback I get, right? We have conversations and it's like, well, but somebody said that they would stop and they can't stop. So isn't that addiction?
The classic image, I think, of an impulse control disorder is the angels and the devils, right? And for, if it takes the rest of my life to figure out why devils are so immediate and quick, it could be something as benign as seeing a Haagen-Dazs stand at the mall, where the devil pops up in one ear and goes, peanut butter chocolate. And then the angels are always like running, wait, that super ego. Now, you've said you're going to try and control, and you've been thinking about your ass, whatever it is, right? And so that battle goes on. And when the devil runs across your neck and kicks the angel off, when we have what everybody can relate to, the screw it moment, if the devil wins, and you go, screw it, and go into the Haagen-Dazs stand, that moment, right, that is a perfect way to consider how one deals with an impulse control issue. How do you juggle your id desires and your superego shoulds?
Very Freudian.
Right? Or as Tom Waits said, how do the angels get to sleep when the devil leaves the porch light on?
Right.
we have to strengthen our angels and learn that, again, we have volitional choice in the decisions that we make. So that blind, I can't stop, I keep trying to stop. I think if you look at it forensically, you can get someone to pinpoint where their screw it moments happen.
And that comment by Dan, I think, also raises a very important question that is also, I think, really one of the worst aspects of the sex addiction industry, right? And again, if you hear the way one of that was framed, all right, if I made a promise to my partner never to do this again, and I broke that promise, isn't that the sign of an addiction? I said, I think that whole context is, and again, I don't mean this as a personal criticism, but that is the core nonsense that so much of this is based on, right? One of the things that this industry does not do, this sex addiction model does not incorporate is, okay, if one partner is complaining about the other's partner, if I am feeling betrayed because my partner is, quote, looking at porn, and let's be honest, it's not about looking at anything. It's a masturbation issue, right? It all comes down to our discomfort with masturbation and self-pleasuring, right? That is the bottom line. But how come nobody ever thinks to question the partner? What are your issues that you are feeling this kind of betrayal? What is it that is going on with you? Again, it's not about blaming anybody, right? Not blaming the partner, but obviously there's an issue that partner has that causes them to take this position. And why are therapists so quick to instantly take on this dynamic of, if one partner is complaining that their other person is doing something without them, why do we instantly get this victim perpetrator model and dynamic that's set up? Right? How come nobody wants to say, all right, you're complaining about this, you have a problem with this, let's see what's going on with you. Why is this such an issue with you? What's happening in the relationship or not happening between you that we really need to take a look at? So, the problem with CSATs and the sex addiction people in general is that all they seem to really want to do is create victim partners and pathologize sexual gratification.
Yeah, it's like, the whole idea, even the question is that if you can't keep looking at porn when you've promised your spouse you would stop, we're promising spouses things that are unrealistic to begin with.
Really?
And the reason the partner is distressed, I don't think it's usually because they've been taught to be distressed. And who have they been taught to be distressed by? Usually, conservative church leaders and, conservative kind of ideology. This doesn't come out of nowhere. It's not like partners are like distressed for no reason. And when you've been taught your whole life that pornography is going to be the bane of your, it's going to destroy your marriage, it's going to be destroyed. And it is your job, by the way, if you're the vagina owner, to monitor it. They're telling you that. Then of course there's going to be distress, right? And then of course the clinicians, who are all religiously biased themselves too, the religious biased clinician takes the side of the wounded partner who feels betrayed by the fact that another person would have their own solo sexual relationship with themselves. And so that, and round we go. And this is why it's so systemic. And this is why it shows up in so many spaces, and why, until we can get, I think, the systemic issues addressed, it's going to be very hard for the people on the ground to know how to manage this. And granted, I'm helping people manage this all the time, and they're doing really hard work, but without that support, right? Because they have to decide, well, am I going to trust the sex therapist, or am I going to trust my entire community, my religious leaders, my mom, my best friends,
my doctor,
versus one sex therapist who's on the fringe saying something different. So you can see how complicated this is. I know we're running out of time. Is there a quick thing that you could say about impulsivity versus compulsivity, just to kind of, again, help people understand some of this language and how we trend to use it clinically?
Mm-hmm. Yeah. But, and I want to say, before I do, I want to, again, just sort of put in this idea that we are just overblowing this whole sense, and we're just missing the point. And to your question about the medical diagnosis, I think that is really a terrible thing, because what it does is it now reinforces all those problematic aspects of this that we were talking about, and now gives more power to the person feeling victimized, and even the therapist supporting that, to be able to say, well, see, I told you, see, it's even my doctor says this now, see, right? And we see this in the medical profession, where the tail is wagging the dog more often than not, right?
Yeah.
We legitimize the issue because we came up with a diagnosis. And we legitimize the diagnosis because we have a medication, right? And this is a whole completely different area to operate on, and I think it's troubling that it's gotten into the sexual arena, right? For me, impulse control is simply not having that little regulator between the thought and the expression, right? That's a lack of impulse control. Right? I want that, again, use those Freudian dynamics, right? Which, by the way, the devil image, that's a Christian thing.
Of course.
How pleasure and all of that became something, right?
Yes.
Something bad. It never existed before that. So that kind of framing, I have a thought, I have a fantasy, right? And there are some people, and some of this is just lack of education. Right? I'm just going to bring it back to that they really don't know. They've never learned that just because you have a thought, it doesn't mean you have to act on it. A lot of people live under that presumption that if I have the thought, I'm supposed to act on it, which is not terribly different than how many guys have this assumption that if I have an erection, I'm supposed to do something with it.
Right?
A very similar kind of script.
It's also creating disease, because if I have the thought, then I'm afraid I won't be able to control myself from acting.
There you go.
Goes back to that lack of agency, that I'm a slave to my impulses. So compulsivity just implies repetitive, and as we were saying with some of the examples earlier, generally ineffective coping. So I think, again, a good example would be the germ phobe who's washing their hands every 5 minutes. There could be consequences. There could be detergent burns and dry, crack, bleeding, infections. In fact, they may ultimately end up with the thing they fear the most because of their compulsive hand washing, an infection, right? But we get how it's compulsive because it doesn't work well. They might only get 5 minutes of relief. I'm confident that I don't have any germs on my hands. I can relax. And now I get back to work and, I don't know who's touched this pen. Now I have to go wash my hands again. So that's where the compulsive behaviors really manifests.
Right. And there is also a qualitative difference in that as well, in people's minds, that there are people who do have true compulsions, compulsive behavior, where they cannot control it. People that have these kinds of compulsions, they don't want to be doing what they're doing. They would give anything to stop, but they truly can't. Where we're talking about the sexual compulsions is people may say that they can't stop, but what's really going on is they don't want to, or they don't know how. Mm-hmm. And those are very, very different issues.
Yeah, and then just to continue with one last comment, he's like, so Dan continues with, so my wife and I go out to a restaurant. She's supposed to be okay with me telling her how hot the girl is sitting at the next table simply because I'm not masturbating over that girl during dinner. It's really only a masturbation issue. But if looking at porn is perfectly okay and masturbating is perfectly okay, then why should my wife care if I look at porn every day and masturbate to other hot women? Or should she not care because this should be normal in a healthy marriage according to you? So to me, this is the beginning of a good conversation that has nothing to do with addiction.
Yes, a conversation between that couple.
Between that couple. Actually, for some couples, they would love talking about how they find other people attractive. For other couples, not so much. Right. If I'm their therapist, I want to know why. Why does it bother you? Why does it not bother you? But but we're not talking about addiction or compulsion or impulsion. We're talking about sexual styles, sexual negotiations, sexual values.
Or just being a jerk.
Why would you do so if your partner says that this behavior really upsets them, and the other partner goes, well, I don't care, right? Or I'm going to do it anyway. That's a problem in the relationship. That's not a sexual problem.
Yeah. Or sometimes, again, like it can go both ways. It can be that the one person is feeling like too much control over the other person. The other person can be like, well, I don't care about you that much to care about how I'm going to behave. I mean, it can go both ways, right? And that's why the complexity of the therapy and the couples work should be complex. It should not be easy. Whereas I feel like with that idea, it's like, well, I if a wife comes in and says, well, he just was looking at somebody at the next table and he told me that he wants to be able to tell me how hot she is, he must be a sex addict. And the therapist is now like, yep, must be. And off we go into sex addiction land. We haven't really talked about any of those issues that couple really just brought up.
And to send this person to inpatient treatment, to take a second mortgage on the house, to pay for inpatient treatment for masturbating? Again, I would concede it's a personal opinion, but to me, unless someone has literally jerked it off and is hemorrhaging, the hospital is the last place they should be.
None of that is appropriate.
To address these issues.
None of that is appropriate.
Not for inpatient hospitalization. And, again, the families involved, which I get with the traditional alcohol, substance abuse model, that it's a family disease and everybody has to be involved. But do the kids really need to know that daddy has a porn problem and has to go away for 2 months to the desert in Arizona to some spa, and the whole family is disrupted and everybody knows and everybody's pointing.
Right. And if you see daddy with his hands in his pants, make sure you tell mommy. You gotta call somebody. I mean, it really is. And unfortunately, and again, I'm glad you recognize the issue in that last comment from Dan. But, I think there's also that sense of, why does everything have to be taken to a level of absurdity, right? In order to try to make a point, right? Because nothing in this conversation really indicated that everything is okay unless you're masturbating to it. That doesn't strengthen a case. It just shows that there's really nothing to hold on to on that other side, logically and rationally. Right. And again, I'm gonna say again, unfortunately, being an asshole is not a diagnosis. So, if you are just not honoring or respectful to your partner, if they tell you that there's certain things that they have a problem with, they want you not to do in front of them, and then you say, like, Ricky said, I don't care, I'm going to do it anyway. You're just an asshole. You're not a sex addict. Right? That's a different issue.
Yeah. Which also shows up problematically with the sex addiction model, because I feel like a lot of people put up with a lot of things. Well, because now you're sick, right? So instead of just saying, hey, you're not respectful to me, we're not negotiating our sexuality well, I don't feel like I'm in a relationship with somebody who is willing to take my concerns seriously. Now it's like, well, I guess you're sick, so I'll continue to put up with your asshole behavior because it's my duty as your wife or husband to put up with, your illness and to see you through your illness.
How many times do we hear people, quote, in recovery say, that was my old behavior? Like, no, I think you're still doing it.
That just happened.
Right. It's not something that just pops up. You're still doing it. Change it. Right. CBT. That's really it sounds like a wise ass answer. Well, if you don't ascribe to the sex addiction model, what's your answer? Psychotherapy. And it sounds like wise assish, but it really is the alternative.
Again, for what becomes that question then, all right? Because it's not just about controlling behavior. It's about addressing psychological and emotional patterns right?
That's
What is
our
the way
job.
we think about it? What are our feelings associated? What are the things inside that we recognize? What do we don't recognize, right? That could be doing this. It's not just about you stop it, right? Right?
Yeah.
So it's a lot more than just that. It's kind for some people, it's a reset. For some people, maybe it would be, you know what, that's not really good for me. I'll stop doing that. But for most people, it's, you have to really get inside and see what's going on. Because, again, another contribution from Freud, that so much of what we do and what drives our behaviors, we're just not really aware of consciously. Right? So the work and the help is to try to be conscious of those dynamics and make those changes as they're appropriate, necessary, and helpful.
Yeah. Yep. Okay. Well, to wrap up, I think just kind of a quick overview. We want to say that, yes, it is somewhat of a challenge to figure out where these things lie, because there's so many different opinions, right? There's different opinions in the mental health profession. There's different opinions depending on what religious culture you come from. But I'll say what I can say, which I feel pretty confident about, whether people agree with me or not, is that your sexual relationship really belongs to yourself first. That's the first sexual relationship you have with a person, is with yourself, with your own body, with your own mind. And I don't think that a lot of times these communities and cultures that we come from that are more conservative really respect that or honor that. They really do see sexuality as something that is really significantly a partnered experience, and that it has to be okayed, quote unquote, okayed by the partner, that your sexuality has to be comfortable enough for your partner to be able to live with. And I do think that that's a problem. I think that's a problem. Mm-hmm. So I would prefer for people to start with, my sexuality belongs to me, your sexuality belongs to you. And then it's our job as a couple, if we're going to be partnered, to figure out, where do we run into some issues? Do we have similar values? Do we not? How do we manage that, et cetera? And that's where I think a lot of this gets conflated, where when there's that conflict, then it's somebody's an addict, or somebody's compulsive, or somebody's impulsive, or somebody's this or that. Now, there are times, I think we've all three said, of course, with any human behavior, it can become problematic, whether it's food, how we spend money, how we parent our kids, how we sleep, any behavior can become problematic. And how that gets defined is also a little bit complicated, right? Because do I feel like, if I'm perfectionistic and I feel like sleeping, 7 hours a day is really problematic because I don't sleep 5 hours a day, because then I could get more done, that's kind of, do I get to decide that that's a problematic behavior? Does my therapist get to decide? Do we have those conversations together? But some of this stuff can be problematic. We can be spending, I probably in the last year, I've met with maybe 2 people in my entire clientele where, they're like, yeah, I'm masturbating. I'm looking at pornography for like 5 to 6 hours a day. It's impacting my ability to be social. It's impacting my ability to date. Okay, great. It sounds like this is out of balance with the rest of your life. I still did not talk about it like an addiction. I did not talk about
more social anxiety.
Right, exactly. We did a lot of that work about what's getting in the way. Why is this an easier route for you right now to survive than maybe taking some of these other risks? And in both of those occasions, it was kind of anxiety and depression kind of combined to keep somebody in behavior. I Netflix sometimes when I'm depressed, right, for hours on end, and I'm like not super proud of that. And then I kind of wake up to that, and I'm like, yeah, this is not really how I want to live my life, and this doesn't really, coincide with my values. But I'm not necessarily dealing with a huge compulsivity issue, impulsivity issue, nor addiction. It's just a course correction, right? Because life is hard, and we all cope with life in lots of different ways. But again, it's not like coping with sex, like you said, it's not like coping with sex isn't somewhat also beneficial. Sex can be a wonderful way to cope with life, just like having good, healthy foods and having a treat every now and then can be a really healthy way to cope with life. So none of these things, it's not black and white. It's not so easy. And so I guess when it comes to, addictions, compulsions, impulsions, oh my, my hope is that we can help people understand these terms better clinically, understand themselves better, understand their relationships better. And just because there's distress doesn't mean that there's a clinical underbelly or a pathology.
Exactly.
And wouldn't it be motivating and exciting if therapists thought of their job as helping folks take the crisis that brought them in and put it in the rearview mirror and have them move forward instead of freezing it into the new permanent thing? Yep.
Right.
You're an addict, you're a partner of an addict. That's your new life forever. And that, like I said, really destroys the lover's dynamic.
And maybe use that initial sense of crisis as the opportunity to strengthen the relationship and understand each other better. Because, let me again I know we're coming to a close, but kind of as an analogy. And again, I think what came into my mind when you were speaking, Natasha, because I think it's a very similar kind of thing. Let's look at sex like music. All right. And, when we look at a relationship, we don't understand typically that the dynamic is, you said, here's a whole person with all of their likes and desires and dynamics and all the things about them, right? Our sex is ours. For our partner, their sex is theirs. They have their dynamics. They have their workings. They have their desires. A relationship is not about how do I become what they want me to become. It's how do we take these two independent sets of things, desires, behaviors, likes, dislikes, and how do we share that space with each other? How do we create that place where we could both do it? Now, I love punk rock music. My partner can't stand it. So if my partner says, I don't want you to play that, when I'm sitting around in the same room and I play a Dead Kennedy song with her in the room, am I a punk rock addict? Right? Am I a music addict because I didn't honor that boundary? Right? Again, we have these desires, these likes, these dislikes, all those things, like you said, that make us who we are. The trick of a relationship is how do we share space, given that we have these two completely different sets of stuff that make us who we are.
We find harmony instead of dissonance.
Yeah, exactly. What do we share? What don't we share? Right? I don't tell my partner everything that's in my head. Right? But I'm not lying. I'm still honest with them.
Right.
Again, we just have these weird ways of defining this stuff that I think is the biggest obstacle. It's less about the behavior than the standards we're trying to hold ourselves and each other to.
Right.
If you told her everything you were thinking, she'd never stop slapping you.
Never stop slapping.
Well, yeah. So I think, just to close up, I think we are all very comfortable saying that the sex addiction model is not a sex positive model. For those of you who would like to think you are practicing in sex positive ways when you're working from this model, it is not the position of the American Association of Sexual Educators, Counselors, or Therapists, which we all belong to, which we've all been certified by, which we are all supervisors for. I believe that's true of all three of us. So that is not okay. That's some cognitive dissonance that we're inviting you to sit with and to do better by your clients by getting accurate training on human sexuality so that we can help people with these distresses and negotiations and self-shame that is usually very inappropriate and doesn't help really with people having the best sex lives that they're potentially able to enjoy and have, especially with partners. Thank you so much for your time.
We're so nuts about you. Thank you for inviting us to spend this time. We'll do it anytime on any topic.
Indeed.
Perfect. And they're both Ricky and Larry are available. If you'll send me kind of ways people can get a hold of you, I'll make sure and share that on our session notes. And both of them are very involved with the Modern Sex Therapy Institute. So that's a great place amongst, other places too, where people can get training for sex therapy. And then I just want to give a shout out and a reminder for two events that are coming up. So April 20th, we have a Reclaiming Female Sexual Desire retreat day that we're going to be holding here in the Ogden area of kind of Salt Lake City area. Kristen Hodson will be joining me. She's a fabulous sex therapist, right? I know you both love her.
And for our best.
Yeah. Kara Burrell, who's also kind of goes by the Nuance Ho. She's going to come and be a presenter. We're going to have also like just some people doing some breath work and some art stuff, like just lots of ways that we can tune into our own female sexuality. And then I have a couples retreat that's coming up in October. If you want more information about that, you can check me out on my website, natashahelfer.com. Thank you so much, especially since we went way over. So thank you so much for your
time. Thank you. It's a pleasure.
We
so appreciate it.
Take care.
Bye.
Bye.
Thank you for listening to the Natasha Helfer Podcast. To help keep this podcast going, please consider donating at natashahelfer.com and share this episode. To watch the video of this podcast, you can subscribe to Natasha's channel on YouTube and follow her professional page at Natasha Helfer, LCMFT, CST-S. You can find all her cool resources at natashahelfer.com. The views, thoughts, and opinions expressed by our guests are their own and do not necessarily reflect the views or feelings of Natasha Helfer or the Natasha Helfer Podcast. We provide a platform for open and diverse discussions, and it is important to recognize that different perspectives may be shared. We encourage our listeners to engage in critical thinking and form their own opinions. The intro and outro music for these episodes are by Otter Creek. Thank you for listening.
There is a place where time slows to nature's pace, and there is space there to find yourself in her embrace. Some places should be left alone. Na tishki say the so we can always go to the homeland of the heart. Of our human history etched on her canyon halls, alongside Earth's mysteries. Some places should be left alone. Nahotishki shade the so we can to the homeland of the heart, to the homeland of the heart. Deep in our cities, we sleep without her stars, yet still her presence sustains us from afar. Some places should be left alone. No tishki shade so we can always go to the homeland of the